Good evening, everyone, and welcome to the New Teeth Now webinar. My name is Bianca, and I'm here tonight with Dr. Richards.
Hey,
and
Bianca.
Tonight we are talking all things dental implants. So welcome. We're so glad you've joined us tonight. We also want to encourage you right off the bat that we're going to have lots of Q&A sessions. So submit your questions live. If you're on YouTube, you can submit them through the comment section. And then if you're on GoToWebinar, there should be a chat box in the lower right-hand corner of your screen. But if you don't see that, there should be a little orange arrow. You can click on that to bring up the chat box. But we love getting good questions from you guys, so send them. We can't wait to answer them. So we'll kind of jump right into things. How are you doing tonight?
I'm doing well, thanks.
Good. So let's get to know Dr. Richards.
Well, before we get to know Dr. Richards, you know, we've been doing these webinars now for a long time, several years, and we have put out so much information. And what's interesting is a lot of the people who come in for consults tell David and me, Dr. K and me, that, you know, I've watched every webinar you've ever done.
Yes.
And so we get so much good feedback that it's really fun to come and do the webinars, because I really feel like we're getting across good, solid information to help people make a decision about what they should do for themselves or should not do for themselves. So,
yes.
But anyway, getting to know me, I'm a Lakeland, Florida native through, you know, Lakeland High School, 1968. I'm 72 years old. I went to Emory University College and Dental School and did a 4-year oral and maxillofacial surgery residency in Jacksonville, Florida at University Hospital, which is now Shands Jacksonville. Came back to Lakeland in 1980. I've been here since then. It is hard to believe 42 years has passed, and I'm still trucking here.
Sure.
You know, feeling good, doing well. And we're doing a lot of good work for our clients, and it's a very satisfying business because Dr. Kirkpatrick and I have just gained so much experience over the years. He's been here with me for 15 years, and you know, we've been on our Zygomatic tour, so to speak, for over 15 years. And that in and of itself has been very interesting, because we're told we do more of that than anybody in the country. So that being said, where are we going from here?
Well, we're going to learn a little bit about implants, but it truly is incredible, like how many cases you both do and the people you get to help. It's just it's an amazing, you know,
yeah, it really is.
So we'll take a look at what a fixed upper hybrid looks like so you can get a visual example. So what are we looking at here?
Well, we're looking at a bridge. If you have a bridge on your teeth, there are teeth that are cut down by the dentist, and then a bridge is fabricated by a commercial dental laboratory, and it fits over the prepared teeth. It's put on with some sort of adhesive. So what we're looking at here with implants is a series of implants. We typically place 6 implants in the upper jaw, unless we're doing a quad zygoma where there are only 4 zygoma implants. And then there's a set of teeth fabricated by a commercial dental laboratory, which just happens to be here. It's ours. And that bridge is attached to the implants with screws, not adhesive. So it's removable for maintenance, it's removable for cleaning and checking all the little parts and pieces, which I will explain what little parts and pieces there are as we go through this. So it is a bridge which is connected to implants. People ask, why is it a hybrid? And the answer is that the implant position and the tooth position are totally disconnected. The implants go where the bone is, the teeth go where the teeth need to go. Some people who have had tooth loss years ago, who have been wearing dentures, have had a lot of bone loss. And so the implants can't go exactly where the teeth need to go. There are other people who have a mouthful of bad teeth or periodontal disease who have more bone, so the implants can go more in a position where the teeth need to be, so the prosthetic or the bridge is a little more dental bridge-like rather than implant bridge-like. But that's my interpretation of a hybrid. Fixed means it doesn't come in and out unless it's unscrewed. Upper, of course, refers to the upper jaw or lower jaw, and hybrid means it's that sort of a bridge where there's a disconnect between the implants and the teeth. And this is a lower. Lowers typically are done on 4, 5, or 6. There are some anatomical things that we come across relative to the nerve in the jaw, which has to do with spacing of the implants and how much available space there is. And that dictates whether we can do 4, 5, or 6. Because the implants, they can't be jammed up like this. They need to have some spacing in between them to have healthy bone in between them. And sometimes you have to do 4. I don't like doing 4, but sometimes you have to, based on spacing.
So that's a great just way to see it. So
Yeah.
you'll just know a little bit more about what is actually going to go into your mouth. And for the new teeth now surgery, so the surgery takes place in 1 day. So you would first be put in a deep sleep under general anesthesia. And then if the teeth need to be removed, they will first be extracted. And then Dr. Richards would place all of the implants, which he just talked about, typically 6 on the top, 6 on the lower, whatever the best for you as the patient. So it depends per patient how many implants are placed. And then while the patient is still asleep, we'll take impressions for our in-house lab to customize the teeth. And then you'd wake up in a private recovery room while the in-house lab is creating those teeth for you. And then at the end of the day, before you go home, the teeth will be placed in your mouth and adjusted. So that's just, you know, a 6-step. It looks really easy there. It definitely, there's a lot behind it, and that's why we have this huge team that's able to get that accomplished every day.
Right. It seems simple when you look at the slide. Take out the teeth, put in the implants, take impressions, and that sort of thing. And it is simple, but if you mess up on one of those boxes at the end of the day at 4:30, when we are putting the teeth in and 1 screw doesn't fit or 2 screws don't fit, then that's a little disappointing because we have to get into resetting cylinders. And so when Bianca went through that and you listen to it, oh, we just, you know, take out the teeth.
I know, it makes it sound
we
really
just put in the
simple.
implants, for gosh sakes, you know, and then we take impressions, and there are a lot of other little technical things, and it just has, each step is so important, and each step has to be done properly for it to turn out at the end of the day. And I think that's something that some of the dentists and oral surgeons who come over to watch us, they don't really have that appreciation because they don't do this every day. We do this every day. And so it becomes sort of automatic, and we don't think much about it really.
Yeah, so the experience
this is what we do.
The experience that like you have and our board certified surgeons have is just, you can't get that anywhere else to have that precision and same result every time. So we're all in 1 day, but we're also all in 1 office. So our surgeons are here, our dental lab, as you heard, is right upstairs, and then our restorative doctors as well. So the restorative doctors are the doctors who help create and fit your teeth. And so we're all under 1 roof, so it's very convenient. You come to 1 place. And we also communicate a lot better because we are all together.
Yeah, we discovered early on when we're doing complicated stuff that being all together is the ticket.
Yes.
And a person doesn't have to get into their car and drive 5 miles down the road to another office and sit and wait and then be seen. And if there's some little glitch here or there, then phone calls have to go back and forth. And so we don't have to deal with that because we're all here. And
exactly.
That's a huge benefit to you, our client.
And this is a picture of our physical location in Lakeland. So we're a pretty large office. The back portion of the building there is our 2 full ORs, and upstairs is the lab, and the front is, we have actually a 3rd OR as well.
Yeah.
And a bunch of patient rooms. So we see a lot of patients, and we have 2 surgeries a day.
So we moved in the building that you see in the front where the orange car is the original building that we moved into in November of 2002. And that original building had 1 operating room, and we worked in that building for a number of years. And then in 2013, we built the 2-story building that you see in the back. Mm-hmm. We just so happened to have that lot. We had attempted to sell that lot all these years, and thankfully no one ever bought it. And so, as Bianca said, downstairs there are 2 operating rooms, so we have a total of 3, and these are like hospital equipped, yes, hospital operating rooms. Our entire office has a generator just like a hospital, just like any other ambulatory surgery center. If the power goes out, the generator kicks on without almost skipping a beat. And the upstairs is the prosthetic center. That's where our restorative doctors work up there, and as she said, that's where the lab is. So the facility is pretty much, we're operating at full capacity right now. Yeah. It's incredible.
It's awesome.
That we've filled it. I never in my life thought that in my career we would fill it.
Yeah, it's pretty cool.
It's crazy.
It's been an innovation.
Yeah.
And so we love to hear from our patients. And so this is Karen. She's from Pennsylvania. So she wore an upper denture for 15 years. And it was ill-fitting. She did not like it anymore. But she also had extreme dental anxiety. Just fear of coming to the dentist. So we're going to hear her story and how New Teeth Now helped change her life.
To go through life not worrying about your teeth is going to be so amazing. I'm a YouTube creator.
Within 2 days, and I got $200 for them. Yep, $200 for an item I have no clue about.
Before I had my dental implants, I deleted a lot of the videos that I made for YouTube, because I would make a video and it's a little surprising to see what your teeth really look like. It's almost worse than what you think. When I first started looking into dental implants, like I said, I researched a lot. I actually looked at going out of the country because of the cost. And I didn't feel confident in that because I knew I'd be traveling on my own. So coming to Florida from Pennsylvania, I knew I would have to stay in a hotel, and I wasn't quite sure how much of a challenge staying in a hotel room by myself would be. But when I called New Teeth Now, I spoke with Shauna and Nicole, and let me tell you, I've never met, and this is the truth, such gracious, helpful people. They helped me find my hotel room. I mean, even during my trip there, they made sure I got on the plane safe. They called me when I landed. They brought me to the grocery store because they knew I didn't have a rental car. I didn't rent a car because I knew I'd be on medicine. I figured I can't be driving. They brought me to the pharmacy to pick up my prescriptions. So the travel was great. Pennsylvania to Florida is only a 2-hour trip, so that was great. And I had a hired driver to go from the airport to the facility. So in the morning when I arrived, I really didn't have too many thoughts because I felt confident in the surgery team. I had met everybody. I was joking around with the anesthesiologist, like, just let me have a good nap. I wasn't anxious about it. I felt like the whole team has my best interest at heart. As I woke up, I was shocked that I didn't feel anything. I really expected to be in pain. I didn't even need to take the stronger pain medication. the professional level, the caring, just the attention to detail at New Teeth now, I've never experienced that. You know, I felt like the whole team has my best interest at heart. When I met somebody new before I had the implants, I felt like I could see the point, at what point in the conversation they would be looking at my mouth to try to figure out what was going on with my teeth. And now I feel just more relaxed, and I think it's more engaging because I smile bigger. You know, I think I put the other person more at ease because it's not awkward. You know, I just feel like I can be myself. So that's been huge. I was in with one of my regular buyers. They said, wow, you look young. Your hair looks great. What happened to you? And they didn't even know it was my teeth. And I was like, oh, thanks. That was amazing. I knew it was my smile. I feel like just being able to relax in life and enjoy life, and when you're complimented, it strikes you as like, wow, I'm not worrying about this anymore. Definitely life-changing, yeah.
So it's, I mean, as you could hear right then, it's just incredible to see the difference. So now she's able to host her YouTube channel with confidence. She doesn't have any more dental anxiety. So it's really just so incredible to see the difference for Karen. And then to kind of get into the differences in the types of implants. So Dr. Richards, can you explain what a traditional size implant is?
Yes, so traditional implants are typically come in different diameters and different lengths. Say the length might range from 8 to 18 millimeters, and the diameter from 3.5 millimeters on the bottom end up to 6 or 7 on the top end. And they're placed in a traditional fashion. In other words, they're put where the bone is, and these are placed just like placing a screw into a piece of wood. There has to be enough width. The wood has to be wider than the screw, and there has to be enough depth so that you can get a screw of sufficient length before you would run into some anatomical area like the floor of the sinus or the lower jaw nerve canal and injure the nerve. So this is a picture of a typical 6 implants in the top with the implants in the back tilted forward to avoid the sinus, and 5 implants in the lower with the 2 implants in the rear, in the posterior, tilted to get the working part of the implant as far back as possible, but to have the body of the implant in front of the nerve canal. So this is something that if we can do it this way, this is keep it simple principle here with traditional tilted implants. We'll go to another slide here in just a moment and show you some stuff that relates to the zygomatic implants. And so this is very common treatment. We probably do, in a typical week, Dr. Kirkpatrick and I may each do 8 or 10 zygomatic implants. And these are the ones that you see in the posterior part of the upper jaw. And in the anterior part of the upper jaw are traditional implants. Now they're not tilted, it's just 4 up in the front where there's bone in front of the sinus. So these are traditional implants. They're placed in a traditional fashion because there's good enough bone width and there's good enough bone depth. In the rear, the sinus will either dip way down towards the crest of the ridge, or the sinus may come well to the front. So usually you don't encounter the sinus until you get back to about the tooth in front of the molar. But in some cases, the sinus will come all the way up to the side of the nose, to the lateral incisor. And so when we have those situations, you have 2 options. You can do some grafting and extend the treatment time out to a year or a year and a half, or you can place zygomatic implants and put teeth into the person's mouth the same day. So the zygomatic implant really is the ultimate solution to avoid bone grafting, avoid the complications of bone grafting, because in our hands, after having done so many zygomatic implants over the years, we just don't see complications with them any more than we see complications with regular traditional implants. And that's also very low to see any sort of complication. So this is an X-ray of a 4 implant up front, where there's traditional implants up front. There's a good amount of bone, width and depth, but no bone in the back because the sinuses are either too far forward, or they drop way down, or the ridge is knife edge skinny. There are 4 reasons we do zygomatic implants, but those that I just said, the sinus comes too far to the front, the sinus drops way down in the back to where there's no bone in the posterior. Sometimes we will attempt to place a tilted implant and it will not be stable. And so that's another instance in which we place zygomatic implants. But the benefit to the person is it's a simple in-office procedure when you're under general anesthesia. They are extremely stable and we can attach teeth to them the same day. So in our practice, the zygomatic implants are a workhorse. I mean, they're not some tool bag, they're not in some tool bag that's over in the corner of the room. I mean, they are out there and we make a decision in a millisecond. We're going to do a Zygoma here. I mean, usually we make that decision at the consult, but occasionally we'll get in there and thinking that we're going to do a tilted implant only to find that it's not stable enough, and then just immediately switch to a zygomatic implant. And they're easy and quick to place, and like I said before, we just, in our hands, we don't see any problems with them. Now there are different configurations, you might say, of zygomatic implants. The illustrations that you saw earlier, where there are 4 traditional implants in the front and 2 zygomas in the back. If you now look at the screen, there are 4 zygomatic implants with a couple of traditionals in the front. Now this is an unusual situation here, because typically when there's no bone anywhere. Mm-hmm. And so typically it's just 4 zygomatic implants. If there's a little bone up in the front where you can put a couple of narrow diameter, 8 or 10 millimeters, traditional implants to supplement those 4 zygomas, I mean, that's great, but it's not necessary. 4 zygomatic implants are very strong. These zygomatic implants, when they go into the cheekbone and they go through the jaw ridge and they go through sideways, not, in other words, if you had a piece of wood and you were screwing a screw into it this way, that's the way a traditional implant would go. Zygomas go through sideways on their way out to the cheekbone. So they're going this way, as you saw in that illustration. And as I said earlier, they're the workhorse, and they are the graftless solution for no bone in the posterior upper jaw. The graftless solution for no bone in the back of the upper jaw. That's huge, because your treatment time just went from 1.5 years or so to same day. Let me repeat that.
That's incredible.
By using a zygomatic implant, you're not doing a sinus lift, waiting 6 months, putting implants in, waiting another 6 months or longer. Or you can't even do a sinus lift if the ridge below the sinus is skinny. So it's well beyond the information that we can fully deliver at a webinar type setting, but these zygomatic implants are so far underestimated in their capability that it really is beyond belief that they haven't caught on better in this country. They're still kind of a bugaboo about them for whatever reason.
But not here.
Yeah,
We
not
do
here.
a lot of them.
This illustration shows, you know, flat out straight 4 on the left, a supplemental to the 4 in the middle, and a couple of supplemental ones to the 4 on the right side. So zygomatic implants. Somebody said, why don't you use those in the lower? Why don't you use zygomatic implants in the lower jaw? Because the lower jaw is the mandible, and the zygoma is the cheekbone. So zygomatic implants go into the zygoma bone. You can go on your computer and Google zygoma bone. That is the cheekbone that forms part of the eye socket. Zygomatic implants are for upper jaw only, front or back, not for the lower jaw.
And actually, while we're on that note, we did have someone ask a question. So if someone suffered bone loss on the bottom due to an inherited condition, I was told I needed bone graft surgery before I can get implants. So kind of discussing like what's the option for the lower if you have bone loss.
Yeah, well, you know, it depends on the lower. We see a lot of people who have been turned down by other doctors' offices, particularly general dentists who are less experienced. And they say they don't have enough bone. But if you get a CT scan and you look at some cross-sectional slices, and if your jaw is sufficiently wide, like from the tongue side to the lip side, you know, if it's sufficiently wide, and even though there may only be, you know, 8 or 10 millimeters of vertical, if it's plenty wide, then you can do traditional implants. Yeah. So, I mean, if you have a really true pencil-thin, knife-edged jawbone, then bone grafting is certainly an option. Also, a subperiosteal implant, a computer-generated subperiosteal implant is another option. We don't do those often, but nowadays with the ability to take a CAT scan and then generate a three-dimensional model of the jaw and have a custom subperiosteal implant made, that treatment is more realistic than it was back when I used to do them in the 80s and 90s. So,
awesome. So yeah, definitely come in to see us for a consultation. We'll be able to take a scan and see what options you would have for your lower jaw. We had another question come in as well. So what is the difference in an oral surgeon doing my surgery or like going to a general dentist?
So, you know, a general dentist would, and what I did, I went to college, I went to Emory University Dental School 4 years, and when I finished that, I did a 1-year fellowship in general anesthesia where I put people to sleep in a hospital operating room under the, you know, under the guidance of an anesthesiologist. I did that for a year, and then did 3 years of oral and maxillofacial surgery. Most oral surgeons do something similar to that, if not more. Nowadays, there's a big move to do 6 years after dental school. Okay, dental school is 4, college is 4, dental school is 4, oral surgery is 4, and then a couple of more years to get a medical degree. So there's a lot of people that do that. A lot of people that just do the 4, 4, and 4. And so now you're dealing with someone, a board-certified oral and maxillofacial surgeon is someone who is highly qualified to do surgery on your jawbones, who's used to dealing with anesthesia, used to dealing with facial and jaw fractures, much more complicated things than putting dental implants in. But more importantly, we're used to dealing with complications. And so as oral surgeons, if I have a complication with a zygomatic implant, who am I going to send it to? There is nobody. I mean, my partner and I manage our own complications. So, would you rather deal with somebody like that or someone who went to 4 years of dental school, they got out and went to some weekend courses to learn how to do implants? That's the difference.
Yeah, it's a big difference.
And so I'm sure there are some of those people that over time learn how to do things, but they can't do general anesthesia. They don't have any training, so they can't get permitted to do that. In Florida, you have to have a certain amount of time to do general anesthesia. We employ nurse anesthetists, and we put our patients, when we're doing this sort of stuff, under general anesthesia. It's not twilight sleep, it's not some pill that you take, it's not IV sedation, full-blown, breathing tube down the windpipe, general anesthesia, so that we can do these procedures painlessly and get them done quicker without problems, choking and gagging and spitting and all that kind of stuff. So, you know, you can make the choice. Would you go to your general primary care doctor for heart surgery, or would you go to a heart surgeon? I mean, it literally is that kind of an analogy, truly. So.
And this is Dr. Richards' team. So we have, we
Right.
have Angie, Allie, and Ashley, except that Allie just got promoted to be an implant coordinator. So I'll have to take a new picture.
Yeah, we do. Well, Debbie Enfinger, who worked for us for probably 25 years, was an implant treatment coordinator, and for various reasons, she decided she needed to retire. And Allie, who is in that picture, as you're looking at that picture, the blonde gal to the right of me, Allie took Debbie's job.
Yes.
So we have hired a new surgical assistant in training, very nice young lady. And you know, my gals, they do what I do every day. What I do every day is this, what we're talking about tonight. And so they do the majority of putting the teeth in, taking the teeth out, checking the screws, checking the parts, checking the pieces, and that sort of thing. Angie, who has worked in general dentistry for a long time, is really good at adjusting the occlusion. And of course, these are temporary teeth that we're dealing with on the front end, because it's our restorative dentist over in the prosthetic center who are doing the final restorations. And of course, the ladies can't adjust or do anything with the final restorations, only with the temporaries. So, but they are a great bunch of gals, and I really couldn't do what I do without them. So can't say enough good
Yeah, they're
about.
incredible.
And there's another team as well with Dr. Kirkpatrick. So, you know, we got a good, hard-working bunch of gals.
Definitely. And we were just talking about anesthesia,
Yeah.
but I guess we can elaborate a little bit more about like the safety benefits and you know why we like try to exclusively use general anesthesia.
Well, let's talk about the education of a nurse anesthetist.
Yeah.
You know, we were talking about a general dentist versus an oral and maxillofacial surgeon. We can talk about an RN. RNs, let's say at Florida Southern College here in Lakeland, you can go into Florida Southern College from day one on the RN program, finish 4 years later with a BS RN, and then you take the boards and you go get a job. You're an RN. Okay. That same RN, let's say they go and they work in the SICU for a couple of years, and then they apply to nurse anesthetist school, and they go to do that. That's another 3 years. Mm-hmm. Okay, so now the person who's delivering your anesthesia is someone who's an RN who's worked in a critical care unit for at least 2 years, who then does a 3-year on-the-job training in a hospital university setting, doing nothing but putting people to sleep under the watchful eye of their trainers for another 3 years, and then they become a nurse anesthetist. Mm-hmm. So in our office, you have us as board certified oral and maxillofacial surgeons and nurse anesthetist. That's who's taking care of you and doing your procedure.
Yeah, so you're in great hands.
Yeah.
Like, couldn't be more safe. And this is our restorative team. So we have Dr. Nafala, Dr. Dibbs, and Dr. Sorrento, and you'll meet with one of them in creating, designing, and fitting your teeth. So you'll work with them in, you know, selecting those aesthetic choices and we'll hear a little bit from Dr. Dibbs. He's going to talk about the process and how he works so closely with the lab.
One of the things that really sets Florida Dental Implants apart from other offices that are doing full mouth implant reconstruction, I have my own laboratory here on site that myself and the other restorative doctors are able to use. This is invaluable. Having the ability to work so closely with my lab gives me the ability to better help my patients with the emotional side of it as well. A large number of the patients that come to us for treatment have had severe dental problems for many, many, many years, sometimes dating back to childhood. Because of the emotional concerns that they have, we really have to spend the time with the patient. That you can't rush anything. We need to have ample opportunity to have questions asked and answered. Having my own laboratory here on site, this is invaluable, not only in terms of having the control over the quality of the product that we're making, but the ability to, if I've got a question with the patient about, can we make this change? Is this going to be feasible? I can go across the hall, get one of my lab technicians, and all of my lab technicians have been doing this for many, many years. Bring them across the hall and they can talk to the patient themselves. So we eliminate the need for me to try to interpret the patient's concerns and questions and needs in a phone call or in a note. They can speak directly to the patient.
It was so important to me to have everything under one roof. There's no waiting. That is the advantage of having the lab on site. And they are so proud of their work that they come out to see the product. These are not regular people with regular jobs. These are master artisans that create. They truly are artists. And they're creating beautiful smiles.
It's like nothing I've ever experienced, and I don't know of any other office that's like this.
So that's our incredible in-house dental lab team, and it's just great how they can collaborate so closely with our restorative doctors. We did have a couple questions come in during the video. So can a quad zygoma be done with low density cheekbones?
I don't know that I've ever seen a low density cheekbone. I have seen a situation where the sinus went well back up in the cheekbone, and I didn't feel like that was going to be something that I could do. The cheekbone on the surface, the Zygoma implant really does not tighten up until the tip of the Zygoma implant comes through the surface, the cortical surface of the cheekbone. And so inside of the cheekbone, it is low density. I mean, it's soft. When we are drilling up through the cheekbone, it's soft, 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 and then boom, you hit the cortical plate, which is the surface covering on the cheekbone. And then once you go through that, then, I mean, you definitely can, you see it because there's a retractor retracting the soft tissue. And so then when the Zygoma implant is being screwed in, sometimes there's a little electric driver that runs at about 45 RPM, screw it in, it'll go in, and then boom. Once it hits the cortical bone, then you have to get the driver, and sometimes it's too hard to even drive it through with a hand driver. You have to back it out, and there are two final size drills. One's a 375 millimeter, the other 4.0, and I always use the 375 first, and if I can't screw the implant in with reasonable pressure, then I'll go back with the 4.0 and actually enlarge the hole, because the connection of the driver to the Zygoma, you could break the implant basically if you twisted on it too hard, if the bone was too dense. So I've probably done 2,000 or more Zygoma implants. I've never run into a, quote, low density Zygoma, because they're all low density on the inside, and it's only when they come through the cortical covering of the Zygoma that it really gets tight. And so you have to select on a proper length of implant so that it comes through out onto the face of the bone, but only just a little bit. So sometimes we'll select one that's too long, we have to unscrew it and throw it away, and get one a little bit shorter and screw that one in. But until it engages the face, the cortical bone, they really don't get tight. And so we don't put them in unless they're that deep to engage that.
So it's secure once it's placed.
Yeah, so low density, I mean, we've got a huge number that we've done, and low density hasn't been a problem, but I've seen just one or two where the sinus went way back into the cheekbone, and the cheekbone was sort of concave up in there, and I just didn't feel comfortable with that, even at my level of experience.
That's a great question.
I hope that answers that.
And then, do zygomatic implants help with upper lip and mouth support?
Well, the teeth are going to do the upper lip support. The teeth will do the upper lip support. Zygomatic implants support the teeth. So if you've lost all of your bone, you basically have a flat upper jaw. In most of those, we can still do Zygoma implants. And so it's the teeth and the position of the teeth. The teeth have to be out there. This is one of those situations like I was talking about earlier about the hybrid. In other words, the implants are going to be back where the jawbone is, but the teeth need to be out where the teeth used to be to support the person's lip. And so the teeth may be well out in front of the Zygoma implants. So there's kind of a cantilever out there. But that's the way the teeth have to be to fill out the lip. And so the smile line, the lip line, and the tooth line, and the smile line, and the lip is supported, and all that, that's based on tooth position. And so can a Zygoma implant support the lip? Only secondarily by supporting the teeth. And the teeth support the soft tissue.
Exactly. And then I always like showing off this image of the Zirconia teeth versus an acrylic set. So we offer Zirconia teeth for the final set of teeth, and that's the top set that you see. So the bottom set on the lower there is the acrylic set. And both teeth that you're seeing here, they've been worn for 5 years. And you can see that the Zirconia set looks brand new. They're white and shiny, and they just look great. And the acrylic set, it's kind of absorbing some stains. It looks a little worn out, just looks kind of dull. And so that's why we don't place acrylic for the finals at all, which some other facilities, like you have like tiered options to do that. But we place Zirconia because we know it's gonna last, a lifetime, doesn't have to be replaced every 5 to 10 years. And it's gonna hold, they're just gonna look beautiful. And our implant coordinator, so you get to see Allie again. So Allie is our newest implant coordinator. And then we have Shauna and Mara, and they all have extensive training, have a dental background as well before they became coordinators. So they know so much about this procedure.
Well, they do, yeah. I mean, Allie was a surgical assistant for me for 5 years. So she can talk intelligently to anybody about anything, any sort of implant procedure. So Shauna also has worked for us for over 20 years, and Maura is a dental hygienist by trade, but is doing this now. And so she's very experienced in the dental field.
Yes, so if you do come in for a consultation or have a phone consultation, you'll be speaking with one of these ladies. And at your consultation, it's about an hour to an hour and a half appointment. We'll first take a CT scan, and then you'll meet with the coordinators and our surgeon. either Dr. Richards or Dr. Kirkpatrick, and they'll go over the treatment plan with you and, of course, answer any questions that you have at that time as well. And this is just an example of, you know, the CT scan, and can you explain, like, you know, why it's so valuable to use the CT like versus a regular X-ray?
Sure. The CT would be similar to having a camera, and you could take a picture of your face from the front, or from the side, from the top, and then have pictures that show different angles. The cross-sectional slices are pictures that we use often because they show the width, and there are other views. The 3D recon is not all that, I don't use it all that much really, but the axial pictures that go up and down the long axis of your body, and the panoramic image, which is in the upper right box, but really those cross-sectional images that you see in the lower right box are very, very useful in treatment planning because they tell us where things are. Things, by things, I mean the sinus in the upper jaw, the nerve canal, and the mental foramen, which is where the nerve comes out of the jaw in the lower jaw. And it's important to know where these structures are located so you have an idea of how deep you might be able to go. So
yes, so you'll leave knowing basically what implants will be placed, like all of that. So
right.
You'll leave with a really good understanding of everything for your specific case. And this is kind of an overview of the whole process. So, you know, let's say you come in for a consult, you decide to move forward with treatment. So at that point, we'll schedule a pre-op appointment and impressions. That's also where you'll be designing your first set of teeth. And then we have New Teeth Now Surgery Day, which we explained in the very beginning, those 6 steps on the day of surgery. And then you'll have some post-op appointments, post-surgery, to make sure everything's healing properly. And then we'll start the process of creating the final teeth. And then once those are created and you're good to go, we place those finals and you're set. So that's, again, another simple diagram that we try to explain it as simply as possible we can for you. And this is Nathan. So he is a reptile trainer and wildlife conservationist who sustained a facial injury from an alligator accident, which was like a catalyst in kind of decaying his teeth. And so he had constant oral pain, and his overall health was degrading as well. So he just felt like lethargic all the time. He just wasn't feeling himself. And so we'll hear from him and how New Teeth Now really brought his life back to him.
When people are afraid, they freeze. So when you freeze up, that will get you killed in my industry. I mean, there's definitely a very, very healthy respect. I've been studying, you know, behavior and all that stuff specifically with alligators and crocodiles and what I work with and train for almost 30 years. I'm not fearless, but I don't ever let fear in the room. One of only 2 times that I was bitten by an animal in my entire life. One of them happened to be square in the face. So I was doing gator wrestling shows, feeding demonstrations, all these different things, and I was kind of laying down on a dock similar to this, and I look over my shoulder and there's another alligator that was spooked by the activity and was already in the air. So as I turned to look over my shoulder to hear what the sound was, here I am turning my face right into a jumping alligator's mouth. And it was about 8 feet long and it clamped onto my face. Now you got to keep in mind, about an 8 to 9 foot alligator is going to have well over 2,000–3,000 pounds of pressure per square inch in its jaws. So a nice good chomp is going to do some damage. So it's slashed up through the cheek, kind of starting down here by the, almost the gum line really. Back over here, through the cheek, through the nose, broke my nose in a couple places. Tooth pain, especially those exposed nerves. It was like this constant, non-stop, incessant pain, as if somebody had like a small little pen knife and just stuck it in there and would just kind of be twisting it. You know, it started getting to a point to where it was affecting overall health. It wasn't just a appearance thing, and then, being a little self-conscious. I heard the ad come on the radio, and I was like, okay, well, there's a option for a solution. Plus, doing it in one day, I mean, you're not really out for the count for too long, work-wise and everything else. Anytime somebody tells you to count backwards from 10, and the next thing you know, you're waking up all like, what's going on? And something new has happened. It's a little, I guess nervous is probably the right word, but excited at the same time.
Drinks on me later.
Okay.
Doing the New Teeth Now experience, from when I got to the office at 7:30 in the morning to get prepped for surgery, that was like one of the best days off I've had in a long time. It was such an easy experience, and it flowed so well.
Looks pretty good.
Looks like new teeth now.
Congratulations.
Thank you very much, sir.
Excellent work.
New teeth now.
I married that man.
That's right.
I was excited to see how much energy I would actually have, like once my body wasn't trying to compensate for, this crazy weird pain thing that was constantly going on. Right away that day, I think when I was coming out of the anesthesia and I was starting to really get my wits about me again, I mean, I could almost notice it right away, like, it was like taking a deep breath of fresh air, like, okay. I don't want to say I feel younger, but I feel younger again. It's like the fountain of youth.
So Nathan has his life back. He's energized and feels younger, and you really can just see the difference, like in his interview, like his after interview, and it's just awesome. So we did have a couple questions come in during the video. So first we have, what issues do you run into with people who have been on Fosamax for osteoporosis?
Well, there's a series of these osteoporosis drugs, the so-called bisphosphonates, and Fosamax is probably the least troublesome of all of them. It's a pill, and but there are others that are injectables, the Proleas, the Reclasts. When you start getting into people that have cancers, the Exjivas and others. So the way we handle those is you kind of look at the other comorbidities. If a person is just on Fosamax and that's it, they have no other risk factors, then we probably would stop the Fosamax for some period of time and then proceed in a normal fashion. But if a person is on Fosamax and they're also, let's say, on steroids because they have some other issue, another drug which also may interfere with healing, then that would raise some eyebrows. For people on Prolia, which is an injectable, if they're only on Prolia, typically it's 6 months after the last dose. Those seem to be the two most common. The Prolia, currently is common. And some of the physicians now are even telling their patients, before we start this Prolia, you need to see your dentist and have a thorough checkup to see if you need any teeth extracted. Because you can still have fillings, you can have your teeth worked on. That's not the problem. It's bone healing. So it's work on the bone, extracting a tooth and wanting the bone to heal. You can still have fillings, you can still have veneers, you can still have crowns, you can have all that because that's on the tooth enamel and it's not a problem. So that's how we handle that, kind of a common sense fashion.
And this person said, my parents passed away when I was very young, so I don't know of any family genetic conditions that could affect surgery, especially the anesthesia, like malignant hypothermia. What do you recommend?
Well, that's a good question. I mean, malignant hyperthermia is extremely rare. About a month ago, I ran into a person, I didn't run into him, I had a consult with him, And we were talking, and the guy said, you know, my mother had malignant hyperthermia. So my brother, he had a surgical procedure and he did fine. And so we got to talking about having a muscle biopsy, which is sort of the end all to diagnosing that. And what we ended up deciding for that gentleman was not to do, there are certain drugs that will precipitate malignant hyperthermia. Some of the inhalation anesthetics, when we use one of those, some of the muscle relaxants, and we use those. And so we decided to do his procedure with an intravenous medication rather than a drug that would precipitate that. So, you know, without a family history of malignant hyperthermia, it's extremely rare. You could have a muscle biopsy if you wanted to, I guess, to rule that out if that was a overbearing concern. But that would be a really rare one to encounter. You know, there's some others, pseudocholinesterase deficiencies, which can prevent the body from metabolizing a nectine, which is a muscle relaxant, but we don't use a nectine, so we don't have to worry about that. But just generally speaking, our clients are 60s and 70s, probably the greater majorities, 50s, 60s, and 70s. And almost everyone in their 50s, 60s, or 70s have some sort of a health issue. A lot of blood pressure, a lot of heartbeat irregularities and things of that nature. People that have smoked for a number of years have obstructive pulmonary disease, so-called COPD. And so unless a person is probably in their 20s, 30s, or 40s and they have absolutely no prior history of anything, we will order labs, some routine labs, like a basic metabolic profile that would show their electrolytes and blood, you know, their hemoglobin and hematocrit and platelets and things like that. But anyone up in the age brackets of the 50s, 60s, 70s, and they've had a stent, they've had an implanted defibrillator, their atrial fib, and they're on a blood thinner, COPD, anything like that, we are getting medical clearances from their primary care physician or the specialist who is taking care of that particular problem. So we get in writing medical clearances on anybody that requires one. So that's how, you know, that's how we manage the health issues, just like any other surgeon would.
Perfect. And then, here we go. So for a final, like, before and after, so this is Bruce. He's from Orlando, Florida, and he had a ton of pain, and he couldn't eat the foods that he loved, so that was like the biggest thing for him. So when he got his new teeth, he was so excited to just be able to eat anything that he wants. And for a lot of our patients, that is something they're so excited to do. We had a patient, I think it was 2 weeks ago, that we brought them over to Fred's, which is like right next door, and got him some lunch. And he just like tore into that fried chicken. He was so excited. So we just love when our patients, you know, get to do the things they enjoy again. And these are our three like key differentiators that kind of sets us apart. So we have, and I'll have Dr. Richards explain, but board certified oral surgeons, zygomatic implants, and general anesthesia.
I think we've already talked about all of those.
Yeah.
So a board certified person, whether it's an oral surgeon or an internal medicine doctor or anybody, you know, they go through the training that you have to go through to be qualified to take a board exam. So in my field, you finish an approved residency program. And then typically they have an oral examination where you sit with your peers and they ask you questions. Mm-hmm. And then there is a written examination. And when you successfully pass those, demonstrating that you have some certain level of knowledge that is, consistent with being board certified, then you are board certified.
Yes.
You are deemed board certified by this body, like the American Board of Oral and Maxillofacial Surgeons. And it would be the same for a general surgeon or a cardiologist or a family practice doctor, anybody like that.
Yeah.
So, zygomatic implants. Well, I talked fairly extensively about zygomatic implants. Just on serendipity, Dr. Kirkpatrick and I came to zygomatic implants around '06 by totally different means. And I had a failed patient with a failed sinus grafts ×3, and I knew there had to be a better solution, and that led me to Canada to do some zygomatic implants with a oral surgeon in Canada by the name of Leslie David, and she had learned the technique from one of the founders of the technique, Chantal Malavez, over in Belgium. And so we got in really early on the zygomatic implant loop, and we have run with that, and zygomatic implants have been very good to our patients.
Yes.
Very good. Have we ever seen a problem? Sure. If you do enough of anything, you're going to see problems here and there. But by and large, pretty much trouble-free. General anesthesia. I just went through the training that I had with a 1-year fellowship in anesthesia and the training that our nurse anesthetists have in general anesthesia. And so I don't really think I need to go through all that again. We are more than overboard adequately trained in anesthesia here to manage pretty much anything in terms of general anesthesia.
Yes.
So, just having the ability to have a general anesthesia permit, otherwise you're having a procedure under IV sedation, maybe, or taking some pills, something of that nature. I think that pretty much wraps that up.
Yeah, that's a great recap. But it's been incredible getting to educate and answer questions tonight, and we're so happy that you've joined us tonight. And I just hope that everyone has a wonderful evening, and we really hope to hear from you tomorrow. So if you have any questions, please call us.
Let me just say one more thing.
Yeah.
That we have, so much more information to get out to you. And we're doing these webinars regularly on the second Tuesday of the month. And this one's on the 3rd because I had to go fishing last week, and I'm sorry. But second Tuesday of the month, Dr. Kirkpatrick and I alternate. We always have a lot of real good, honest, down-to-earth, whatever you want to call it, the real deal information. So feel free to join in again, and you might hear something a little different. You might hear the same thing a little different. But every time you watch, you're going to get a lot of good information.
Yes.
So have a good evening.
Have a good night, guys.